We are in the live Q&A session for blood flow augmentation technology. And joining me here for this live session is Dr. Joe Holley, who gave our State of the Technology presentation, participated on the panel, and is joining us live from South Florida, where he's deployed with FEMA down to the building collapse. But Dr. Holley really wanted to be part of this live Q&A session. So we will try to make the best of his limited connection. He's on audio only, and we'll, just like we do in EMS, we adapt and improvise and make it all work, Joe, right?
Absolutely, Mick. Thanks. I've got a little bit of downtime here and a pause in activity, and I'm happy to be able to jump on and participate. And trust me, you do not want my video feed to be on because I am not a very attractive sight right now.
All right, we will just take your word for that, Joe. Well, terrific.
Deal.
So we're going to do the best we can with the questions and dialogue. And what's actually happened with a lot of these question and answer sessions is some of the information is coming through on the chat window. Sometimes it comes in through Q&A, and many times it ends up trying to just being an extension of the panel discussion in many regards, which is fine. One of the things that I would like to elaborate a little bit more on is the dilemma you face, perhaps as an EMS medical director, in trying to take an agency that hasn't really taken the bull by the horns on improving their basic CPR technique yet, and the agency wants to try to move forward with mechanical CPR. Would you discourage them from making the purchase until they've started collecting the data off of their defibrillators and measuring manual compression performance and trying to optimize that before they make the purchase? Or do you think those things could be done in parallel?
Well, I think your idea of establishing where am I right now makes an awful lot of sense. I believe, though, that you can do those things simultaneously. I think the use of particularly, for example, a mechanical CPR device is not only about attempting to improve your compression efficiency, but other things play into that, like how many crew members you have on scene, what's your transport time, do you do a lot of transports while you're attempting to do CPR? So those factors are definitely important as part of your decision-making process. But it is still part of the, if I'm going to spend money on this device, I want to make certain that I am gaining something from it. I need to see return on my investment. So looking at those basics to give you an idea of, I started here and now I'm at some other spot, and is that better or worse than where I was before? So you can make intelligent decisions about your investment in technology.
Yeah, and the way I kind of look at these things, Dr. Holley, is when you buy new technology, it's an improvement hypothesis, because I feel very strongly about the notion of improvement science and improvement using the scientific method, so that we have the assumption or presumption, if you will, that when we introduce this new piece of technology, that it will result in an improvement in the outcome we're trying to influence, in this case, survival from cardiac arrest, or an interim variable of just improving my compression fraction and CPR quality, perhaps just during the transport phase, as you pointed out. But absent that measurement, I guess I still have a lot of concern about whether or not the technology is going to make a meaningful impact, because I think we've all heard stories about the introduction of perhaps automated CPR is a good example. They brought the technology in, but in so doing, they introduced these sometimes very extraordinarily long pauses in manual technique.
No question about it. So I think that's back to the conversation that we had earlier related to ensuring that you understand not only how the device or product can help you, but what do I have to do to get maximum benefit from the device or product, and then what factors influence the difference that the device is likely to make. So if there's not room on your vehicle to carry that device, then you got to give something else up in order to fit it in. And what are you going to give up? So all of those factors play into that. I agree with you that I think that the common mindset is it's new technology and it should make things better. So let's get that, and that'll fix all our problems. And I think that's just a way too narrow view of the use of the device and how it's going to fit into your system in many different aspects.
Yeah, and and the reason I bring this up is this is kind of the kind of questions that I've heard commonly about introducing this technology is, Mick, I'm not in the CARES registry. We're not measuring our cardiac arrest survival rates. We're not measuring our perishock pauses, our compression fractions, our rate compliance, ventilation rates, any of those things. We're just out here trying to do the best we can when we do have a cardiac arrest. And the buzz in the industry is that these devices help with consistency and quality of compressions. So, what do you think the benefit would be to us by getting this technology? And again, just doing the best we can, put it in place. And the thing that bothers me is it will give the appearance of an improvement. You'll see, the device being used. It's, now being used as you're moving the patient on a stretcher, driving down the road if necessary, because you're not working your codes completely on the scene, which is another conversation. But recognize sometimes that's necessary in some circumstances. But nonetheless, you can have this sensation that you've made an improvement when actually the net result of introduction of the technology may indeed be more of a negative. Does that make sense to you, Dr. Holley, or do you think I'm off base here?
Oh no, I think you're 100% correct, and I think that's part of the challenge of assessing new technology and really understanding its role in the things that we do to take care of patients. So, as is often the case, and as we sort of mentioned in our presentation earlier, the idea that I implemented this device and nothing got better, so the device must not work, is often a false train of thought. And in reality, in some cases, the issue is because you're not using the device correctly, or you are pausing too long, or you're not doing good quality CPR to allow the device to function as it's designed. And therefore, I wouldn't expect to see your results improve. But that's a hard thing to take a very objective look at your system and to appreciate that maybe the problem's not the device, maybe the problem's me. That's a tough thing, and that takes a very dedicated and disciplined evaluator of the product and the system to make certain that the two match up to the benefit of both.
Yeah, and it does require some organizational maturity to be willing to look objectively at your performance and recognizing that when you lift up that rock, it might not line up with the PR that you're trying to generate for your agency. Uh, and so I think that's been, one of those. We've talked about psychosocial barriers to bystander CPR. Well, I think this kind of plays into some of the psychosocial barriers to improvement in EMS and healthcare in general. Is you've got to be willing to be humbled by looking at objective evidence of your actual impact. And so, it can be not just a technical issue, but a psychosocial issue. What do you think about that bent on it, Joe?
I think that definitely plays a role in it. There's just no question that it's not just the device that makes the difference. It's how you utilize, implement, and incorporate the device. And you can do a lot with very little if you are imaginative and dedicated and disciplined in how you do that. But you can also squander an awful lot of money for products that ultimately make no difference at all and may make things worse because you're unwilling to look at the issues around the implementation and use of the device.
Yeah, indeed. So we've got a ways to go as an industry in coming to this reckoning of measuring our performance and having not only internal accountability, but perhaps in the longer view, some external accountability for how good a job we're actually doing, which in many ways can be fortunate because as you identify these problems, it may increase your opportunities to get funded. So a lot of factors come into this. Joe, I really appreciate you being here for the live Q&A and this continuation of the discussion. And we're going to go ahead and close this session off. All the best to you in South Florida, and our hopes and wishes and prayers for everyone involved in the incident down there. Thank you so much for being here.
Thanks. It's a pleasure as always. Enjoyed it greatly, and I appreciate the support. Thank you so much.
Thank you, everybody.